I'll show you with a special type of x-ray here where some of the components are. And the graft is almost completely in. We're going to put that short leg that you were showing in next. Ready? Okay.
So Barry, as risky as these are to patients, and as much as they can be life-threatening, we should mention that most aneurysms are actually found accidentally. They're found because patients have other types of workups. Aneurysms are known to be silent killers. Most patients don't even know they have these. So we do believe that patients should be screened. In fact, patients who have a family history of an aneurysm, men who are smoking over the age of 55, should be screened for aneurysms. And the way to screen is with a simple ultrasound, but sometimes a CT scan can show that, which is how most of these are found in the emergency room when we do other things. And it's very important to understand that you may not have any symptoms at all with this aneurysm. So, again, as we're watching and we're looking at the work here, they're working with their hands on the outside of the body, and you can see the catheters moving inside in the aneurysm sac with the spine projected in the background. So, how long have we been doing these interventions? Well, we actually, here at the Institute, started doing these as early as 1994. But the majority of devices available weren't available to the general public until about between 1999 and 2001. We actually participated in a lot of the original research that was done to get these devices approved, so we have a very big experience here. We've been part of a number of the clinical trials that have been run through the FDA to get these devices approved.
Can I get the sheath up?
Yeah, I can do that. Let me have the dilator first. Jim?
Yes, Barry.
So what we're doing now is we've successfully catheterized the other limb, the short leg, and you can come to me if you want, and I'll talk to the audience. And what we're doing is we're using several different techniques to facilitate getting the device up, and so sometimes this can be challenging. And from a technical point of view, that's what we're doing now. And if we go through this will make it a lot easier. And what we've just seen, if you look at camera number 4, is we've re-engaged the short leg with a sheath, which is a tube that allows us to facilitate things. Now, I know you were talking about when we started this, and interestingly enough, the first patient was treated this way in 1990. In an experimental and a research way, and we started here at Baptist Cardiac and Vascular Institute in 1993 doing this kind of research. Can we come here? That research was led to ultimately to approval of a couple of devices in 1999, and then other devices, next generation devices such as this, subsequently. So. We're still doing research here to improve devices, improve outcomes, and to get the best possible results for our patients with the least level of invasiveness. So here you can see the device going up, and I'm going to pull the sheath down. So you can see here, you can see the sheath moving, and there's some different, those little black dots basically allow us to really identify where everything is, and they get us oriented. Now Dr. Rua is going to deploy this device, and you'll be able to show, I think what we'll do is we'll show you the fluoroscopy this time, just so you can see. And you can see we're lining up 2 dots. So this is a little bit like we're lining up 2 dots. There's a short dot and a long dot. And now Dr. Rua is going to go deploy. 3, 2, 1. Okay, and there you can see the device opening up very nicely. Okay? And now we can take this device out, and we'll take the balloon up.
Barry, just to remind everyone that joined late, we're repairing an abdominal aortic aneurysm with a less invasive technique called an endograft. We're at the Baptist Cardiac and Vascular Institute in Miami. Feel free to ask a question. You can just click the tab, ask a question. And the other thing I wanted to mention is that if you have friends or anyone that you think that may want to see this, they can watch this delayed by going to the same website, baptisthealth.net, and you should be able to watch it again this evening or any time in a few hours. So we're very excited.
What we're doing now is we're just putting a balloon up, and this balloon, again, helps us provide sealing. So you'll see the balloon go up. This is inside the graft. So we have junctions of graft material where the graft overlies two pieces overlie each other, a little bit kind of like a rector set. Yeah, keep it right
take
there.
That off.
No. Okay. And we're basically constructing this device inside the patient to protect him from rupture by replacing his diseased pipeline with this totally new synthetic type pipeline to protect rupture. One of the amazing things is, although this looks highly technical, and it certainly is, because of the less invasive nature of it, let's have the straight flush, please. Before the less invasive nature of it, this patient will go home likely in 2 days' time. Come back to me. The patient will go home in 2 days' time, and likely will have a much more rapid recovery than open surgery. What do you think about that, Ignacio, compared to open surgery?
Yeah, typically, the patient will be here 24 to 48 hours, and a typical surgical stay, if we have to open the abdomen, will be about 5 to 7 days.
And Ignacio, the other thing I think we have to mention isn't just the hospital stay, but when this patient goes home,
go around the other side.
This patient will be back to complete normal activities within a week to 10 days, whereas sometimes with an open surgery, when you cut through the abdominal muscles, it can take several months before the patient's actually walking and doing everything completely normal.
Okay, Jim, we're going to come back to the overhead camera, and I just want to show everybody, Dr. Rua is advancing, putting the catheter in. Go ahead, Ignacio. And he's looking under floor. We've got three things going at once here. I've got this sensor that's a little bit like a space age. That's fine. Don't go up too high. Pull it down a little bit. Pull that first side hole just above. Keep coming down. Keep coming down. Keep coming down. Okay, right there. All right, let's flush this. And you can also see that we put the tennis racket, so to speak. It's obviously not a tennis racket, but I'm just going to move the light here so you can get a better view. You can see this right here. And again, this is just a little bit of a microwave device, and what it does is it kind of pings a little radio transmitter signal, just like a cell phone might. And what we're doing is we're actually reading that signal, and you can see our monitor over here as soon as we're ready to go. And remember what we looked at before. We're going to show you here. So you can see, remember that the pressure here was very high. Remember before we treated, and that was the pressure in the sac before. And now, without doing x-rays or anything else, I know that, in fact, I've been able to drop the pressure in this gentleman's sac to an area where he should be protected. Now, there are a lot of other things we have to look at, but this patient can come back into my office in a month or so, and just very simply using this device, I can actually measure the pressure in the sac and identify exactly what's going on if there's any particular problem. So this is a very, very good demonstration of how we can use these microchips and this sort of next generation nanotechnology, so to speak. So I think what we're going to do now is we're going to go back to monitor 4 and show you a little bit of where we are now. And I think all of you remember what the sac looked like before. And what we're going to do now is just do a very minimum injection of contrast, just a test injection. If we can get apnea for a moment. And if you watch just 1 second here. Oh, it looks beautiful. So,
very nice.
You can breathe? Yeah. So this is just a first look. And I think what I'm going to do is I'm going to take the balloon back just on the right side and just sort of touch this up a little bit. And for those of you that came in late, so to speak, what I want to do is go back and show you this patient's aneurysm. Remember, this is what it looked like before we started. You can see that big bubble, the big bubble in the aneurysm. That's what this that is the aneurysm, the big bubble in the patient's abdominal aorta that Dr. Beninati showed you the diagram of. And I want you to remember this because in just a moment we're going to take a look at what it looks like now. And what we're doing now is mag up, please. Mag up to the upper. What we're doing now is just putting a balloon up because what I'd like to do is just make sure that we have the best possible seal. Ignacio, watch your legs for a minute. Just step this way from it. Gotcha. I just want to make sure, and I'm using these markers again, even though we haven't operated and we haven't opened the patient's abdomen, I can kind of see it. It's not exactly X-ray.